Hello everyone, today I'll be discussing nocturnal enuresis and its diagnosis, disorder overlap, and treatments. Nocturnal enuresis is defined as a benign parasomnia in which the individual experiences involuntary bedwetting. Unlike other parasomnias we have studied in class, nocturnal enuresis is not restricted to a specific sleep stage, therefore categorized as other parasomnia. Divided into two parts, nocturnal enuresis can have different circumstances. The two types are as followed: primary enuresis, which infers that they have never had a period of dry sleep, or secondary enuresis, where they experience a period of at least 6 months without wetting and later develop. While urination during sleep is present in 100% of infants, it often resolves when daytime continence of urine is achieved. However, a study conducted by the Avon longitudinal study of parents and children showed that a failure in achieving nighttime urinary continence has a prevalence of 15.5% at age 7 and a 1% at age 18, indicating that while it decreases with age, it is a common issue among children. When it comes to diagnosis, most are clinically diagnosed given an involuntary voiding of urine twice a month for a period of 3 months. However, the International Classification of Sleep Disorders has a more selective basis, requiring recurrent bedwetting during sleep at least twice per week for a minimum of 3 consecutive months. With these reoccurrences in mind, it is also expected that the child be a minimum of 5 years of age, as it is often resolved past this developmental stage. Within this diagnosis, the individual may be classified with either primary enuresis or secondary enuresis, as discussed prior. It should be noticed that primary is also known as monosymptomatic enuresis, meaning that they have no other medical abnormalities accounting for this disorder. This differs from that of secondary, otherwise known as polysymptomatic enuresis, which usually occurs due to underlying medical issues such as diabetes or urinary tract infections. However, if the individual is experiencing bedwetting due to more serious complications such as seizures, they will not be diagnosed with nocturnal enuresis. Finally, although polysomnography would show the voiding of urine through spurts of arousal, it is not needed for the disorder to typically be diagnosed. Moving on to the physiology of nocturnal enuresis, in our hypothalamus, our suprachiasmatic nucleus helps us regulate almost all circadian rhythms in the body, including urine production and storage. This applies during sleep, with increased antidiuretic hormone regulated by our osmoreceptors and the SCN helping suppress urine production. However, the flow of urine from our kidneys to our bladder is never fully suspended. It is the job of our central nervous system to interpret the message of a full bladder and properly inhibit bladder contractions. For this to occur, a certain amount of arousal must be reached. When children are dry at night, they do not wake to go to the bathroom, but rather hold their urine in through the entire night. Thus, it is not that their bladder capacity is small or that their urine production is abnormal, more so an imbalance between the automatic functioning of the urinary system and the ability to exert sphincter control. Like many disorders, there often exists a correlation overlap, obstructive sleep apnea and nocturnal enuresis being one. Defined as a sleep-related breathing disorder which partially obstructs upper airways, OSA fragments sleep, increasing homeostatic sleep drive. As a consequence, individuals with OSA have a higher arousal threshold, meaning it takes a greater stimulus to create a response. Therefore, it will be harder with a child with sleep apnea to interpret the message of a full bladder and properly inhibit bladder contractions. Additionally, it has been explored whether brain natriuretic peptides, BNPs, affecting the circulation in the kidneys might be involved. The hypothesis suggests that increased respiratory effort leading to cardiac distension triggers higher circulating plasma BNPs, potentially explaining the increased risk of enuresis in the group. However, while sleep apnea increases the risk of NE, not every child with sleep apnea experiences it, and most children with NE do not experience sleep-related breathing issues. While there exists a myriad of possible treatments, for the sake of concision, I will focus on non-pharmacologic and pharmacologic treatments. Starting with non-pharmacologic treatments, the most intuitive treatment is reducing fluid intake just before bed. This method can be helpful as it reduces the demand on the bladder capacity. However, it has not been clinically proven to help long-term. Among all available treatment options, the most effective and lasting approach is the use of an enuresis alarm. In the course of 3 trials conducted by the Cohen Incontinence Group, the overall success rate of the alarms were 55 to 75%, with a low relapse rate. The alarm is a moisture sensor fixed to the undergarment. When hearing the alarm, the child becomes aware that urine has escaped and should quickly stop the stream. A stronger signal, such as the alarm provides, helps overcome the high arousal threshold. Reviewing the nighttime plan and practicing that plan before bed helps the child remember to hold their urine in on waking. The success of the treatment is seen in the case of 7-year-old JL, who despite passing a comprehensive assessment, still experienced bedwetting. However, after 6 weeks of employing the enuresis alarm consistently and reciting the nightly plan before bed, JL started having dry sleep. Finally, the last treatment is scheduled wakings, in which the parent brings their child to the bathroom at night to reduce the volume of urine in the bladder, therefore reduce the likelihood of an enuretic event. While being easy solution, there is not a lot of evidence showing its effectiveness in clinical practice and tends to result in the disruption of sleep for both the child and the parent. When it comes to pharmacologic treatments, medication for NE tends to have 3 effects, which are to reduce the flow of urine, reduce the contractions of the bladder, and lower arousal threshold. The most common being desmopressin, which is a synthetic antidiuretic, decreasing the amount of urine produced. While having the same effectiveness as the alarm, the child may become reliant and therefore increases the possibility of relapse if discontinued. Thank you all for listening, and I hope you enjoyed my presentation.